Wonderful. 3, 2, 1.
Well, good morning, everyone, and thank you for joining our second virtual Bipartisan Opioid Task Force Roundtable. Today, we will be discussing how technology can be leveraged to prevent opioid misuse, diversion, and death. I look forward to our discussion on how clinicians, healthcare systems, private industry, and standard-bearing organizations look to innovative ways to address the epidemic. My hope is that this conversation will inform us as policymakers as we continue to legislate on the opioid epidemic. We have 4 participants here today, along with several members who would like to speak, so I'm going to keep my opening remarks short. Thank you all for joining us. And with that, if Congressman Fitzpatrick is on, I'll turn it over to him, or Congressman Norcross. If not, I know that we have David Trone, if you'd like to say a word.
Oh, that'd be great. I'll tell you, I think today is really important to continue this dialogue. Yeah, I was talking to Jim Carroll yesterday, who's the director of the ONDCP, and Kemp Chester the day before. And I probably will talk to them again today. And what we're seeing with COVID is just a dramatic resurgence of overdose deaths, across the country. The isolation on top of the mental health challenges we've had that have always been underlying. The mental health has also been just hammered. When I talk to my CEOs of the hospitals, which I do every 6 weeks, they are unanimous that their admissions on mental health challenges used to be in the top 10, now we're in the top 5. So we're really seeing and as we all know, these are so interrelated. So this discussion today should really be helpful, especially when you see an opportunity to talk about the reality that we're living now and probably for the next 12 months until the vaccine is, widely available. It's not a good situation.
Thank you. I couldn't agree more. In New Hampshire, we've seen a 30% increase in overdoses at the hospitals, and tragically, a 30% increase in overdose deaths. So it's really, really troublesome. Well, I think what I'll do then is just dive into the discussion, and as members come, if Representative Fitzpatrick or Norcross show up, we'd be happy to go to them for comments. We'll dive right in. I'm very pleased to welcome Jeff Wall, who is co-founder and president of Midas Healthcare Solutions, a venture developing unique products and systems which provide safe handling, tracking, and tracing of controlled substances and other high-value pharmaceuticals in healthcare institutions and in the home to prevent diversion. That's an important part of this. Let me just introduce the 4, and then, Jeff, we will ask you to speak. We're also delighted to welcome Steve Mullinex, who is Senior Vice President of Public Policy and Industry Relations. The National Council for Prescription Drug Programs is a nonprofit standards development organization that creates national standards for electronic healthcare transactions used in prescribing, dispensing, monitoring, managing, and paying for medications and pharmacy services. Mr. Mullinex's expertise as a pharmacist and long history of work with organizations that develop industry standards brings valuable insight into pharmacy-level use of prescription drug monitoring programs. And we know that the PDMPs have been an important tool in the fight with the opioid epidemic. And it's just tragic, some of the stories before we got onto this more seriously about the quantity of opioid medication that was going out to some communities. I'm pleased to welcome Rachel Uslick, the Vice President of Quality and Clinical Operations at Twin City Orthopedics, where she supports operational quality, ambulatory surgery centers, and patient-reported outcomes Twin Cities Orthopedics is a 120 physician private orthopedic practice in Minnesota and Wisconsin, and an ally of the Collaborative for Effective Prescription Opioid Policies. CPOP, as it's known, was formed more than 5 years ago to develop, disseminate, and advocate for comprehensive and coordinated solutions to the opioid crisis and priorities for prevention, safe use, and appropriate prescribing, and safe disposal and anti-diversion. And lastly, a warm welcome to Dr. George Blake, Chief Quality and Value Officer for the Dartmouth Hitchcock Health System. Excuse me, let me try that again. Dr. George Blake, Chief Quality and Value Officer for the Dartmouth Hitchcock Health System in my home state of New Hampshire. Dr. Blake's research has been devoted to creating patient safety in complex, high-hazard domains. He's performed applied human factors research to improve the safety of pediatric procedural sedation and to reduce the risk of pain management in the hospital and opioid overdose deaths. And I'm especially grateful for his research, as it has informed legislation I'm currently working on to stop opioid deaths in the hospital setting. So thank you, Dr. Blake, for being with us. We usually say thank you for making the trip to Washington, but hopefully this was more convenient. So I'm going to turn it over to the panel for a few minutes of opening remarks, and then my colleagues will be here for any questions that you may have. Mr. Wall, the meeting is yours.
Thank you very much. Chairwoman Kuster, Chairman Fitzpatrick, distinguished members of this task force. Thank you for the opportunity to participate in today's discussion of technology and prevention. Along with founder, pharmacist, and entrepreneur Michael LaFauci, we created Midas Healthcare Solutions to develop technologies to solve real-world opioid diversion issues and to reverse its rising trend, which in turn fuels the opioid crisis. Drug diversion, as small as giving a pill to a friend or a colleague, or as large as intercepting a shipment of narcotics at a hospital loading dock, is a worsening epidemic in both institutional as well as home and community settings, particularly as it collides with COVID-19. It causes serious repercussions to healthcare providers and their patients. Diversion occurs due to weaknesses and vulnerabilities in the security and accounting of opioids and other dangerous medications. It exists because of a gaping hole in the technology safety net. The equally alarming parallel crisis in our homes highlights our collective failure to monitor, secure, protect our children, and responsibly dispose of unused opioids and other addicting medications. The 2017 report by the President's Opioid Commission said it best. Having a slight technical glitch here, sorry.
No problem.
Well, we're going to the paper.
Do you want us to give you a minute?
No, it's fine.
Oh, okay, go ahead.
It's fine. Sorry. The 2017 report by the President's Opioid Commission said it best. Stakeholders need timely access and accurate information that provides a comprehensive view of the drug environment. Existing regulations and procedures for handling, documenting, and destroying excess medications seem antiquated when compared to the burgeoning use of technology in almost every other aspect of healthcare. In hospitals, medications are dispensed with multiple levels of security, record keeping, and auditing. But unused medications must be wasted to ensure their destruction. Unfortunately, current wasting practices employ low-tech containment and disposal solutions such as toilets, sinks, garbage cans, sharps containers, and paper records. It is simply absurd that controls on controlled substances disappear once medications leave the pharmacy. In 2020, we need medication wasting kiosks for home and hospital environments that function like the most sophisticated touchscreen automated teller machines and workstations instead of using products you can pick up at Home Depot. A parallel pervasive situation exists with opioids and other dangerous medications purchased at retail pharmacies. Again, controls exist up to the point that the prescription is filled. No comprehensive solutions monitor medication usage, assure safe handling and destruction, and encourage patients to remove leftover medications from their homes. Legislation proposed by this task force could catalyze development of tech-enabled solutions to prevent institutional and home diversion and better overall control of opioids and other drugs. Here's a dose of reality. Drug diversion by healthcare providers is a massive problem, with reportedly up to 400,000 medical professionals who divert and abuse. Commercial detection software only provides reactive analytics, but does not prove safe handling or destruction. Consumers can use commercially available digesting materials for their medications or return them to take-back boxes, DEA-sponsored or others. Yet none of those solutions provides any meaningful, accessible, actionable data important to prescribers, pharmacists, and government stakeholders. My written testimony outlines a series of staggering statistics about medication hoarding, but here's one that stands out. There are almost 400 million unfinished bottles of pills in our homes. That's more than one unfinished bottle for every person living in the United States. We know why people stockpile medications, but with technology, prescribers can become more comfortable with their patients as medication stewards and write more precise prescriptions. Patient self-reporting is inherently unreliable, so let's allow technology to do the reporting for patients by tracking how much medication is returned unused. Together, we can break the cycle of medication retention, diversion, and misuse. A topic of interest to this task force, PDMPs, effectively track sell-side prescription data, but their scope is limited by their data sources. PDMP utilization and take-back utilization can expand if bolstered by cutting-edge technology producing clinically relevant real-time utilization data. An enhanced take-back kiosk, which destroys return medications immediately after the return is confirmed, would prevent post-deposit diversion. This new system would render moot the DEA prohibition against inventorying the contents of the collection box and outdated anti-diversion regulation. The President's Commission hypothesized that financial incentives for returns would increase collection rates. A recent study from the VA proved just that. Buyback programs work to increase the volume of returns while reducing the amount of subsequently prescribed medications. We propose a combination of behavioral economics-based incentives with digital tracking to reduce medication hoarding and its consequences. Midas is developing new technology that transforms tracking and wasting medications in hospitals and in retail settings into a safe, streamlined, and verified transactional model. Instead of unreasonable reliance on the honor system, Midas's kiosk systems build on technology currently used in two heavily regulated industries, banking and gaming, to create a permanent record for the waste return transaction with verification of both the event and its contents. We propose a public-private partnership to study and develop intelligent medication wasting and return systems which facilitate greater medication stewardship by providers and consumers. Incentives could become user-directed donations to help treatment recovery programs, turning returned bottles of pills into returned bottles of cash to help those with substance abuse disorders. In conclusion, few improvements to the processes envisioned by the Secure and Responsible Drug Disposal Act have been developed or implemented in the past 10 years. Now, technologies can provide more responsible handling, record keeping, and destruction of divertible medications, safeguarding our hospitals and our homes. Technologies being developed by companies like Midas will improve delivery of healthcare in coming years by improving prescribing practices for those patients who need medications without reducing availability to those who need them the most. The support of Congress and the DEA for these kinds of partnerships can reduce diversion, make us all safer and healthier, and prevent new incidents of substance use disorder. The public-private partnership we propose would provide a substantial return on investment. Thank you, and I look forward to this conversation.
Thank you, and what an interesting concept of technology solving a substantial part of this problem, which is diversion. And, you know, so many people that have this medication in their medicine chest and just don't know how to safely get rid of it. I have to apologize to my colleague, Representative Fitzpatrick, joined by phone. Brian, if you can hear us by phone and you would like to say a few words, now's the time. I don't see the phone on there now, so we may have missed him, but hopefully he'll come back.
I think Brian may be on as a participant.
There we go. Brian, are you
You got me?
on? There we go. Sure.
Yeah. Sorry, I was having technical difficulties this morning, but I'm glad to be on. And thank you, Chairwoman Kuster. And I know I just missed Mr. Wall's presentation. I've got to meet him through former New Jersey Governor Christie. He is really, really insightful, and I know we have a great number of panels here. So I just wanted to let you know I was on. We can continue with their presentations. I do have some questions for the panelists, Chairwoman Kuster, when we're done.
Great, thank you, Brian, and thank you for bringing Mr. Wall to us today. He has a fascinating new technology for the return of unused medication. Number one, we could keep track of it better. Number two, we could dispose of it more safely. I myself had a personal story trying to help my son after he had surgery. He's in law school down in Charlottesville, and I went back to the CVS to try to return the medication, and they wouldn't take it. And I was like, what do you mean? What? I just want to get rid of this. And they said, oh, we don't sell those bags anymore. And I said, well, I don't want to buy the bag. I want you to take the medicine. And it just was so frustrating. Finally, I had a minor hissy fit as a mother. He said, lady, I'll take your medication. But it shouldn't be that hard. You know, my son didn't want to have the medication around, you know, so. All right, well, this is clearly going to be a fascinating discussion. Next up, Stephen Mullinex, and Stephen is Senior Vice President of Public Policy at the National Council for Prescription Drug Programs. So Steve, thanks for being with us.
Well, good morning, and thank you, Chairman Kuster. I think I first want to thank the members of the task force for their concern regarding the increasing epidemic of opioid misuse and abuse in this country, and their sustained commitment to finding ways to assure safer use of these important medications. Also, on behalf of NCPDP, I want to specifically thank Representatives Kuster and Mullen for their efforts relating to the ALERT Act, which would actually implement a patient safety facilitator model that I will be describing today. Lastly, I want to thank you for allowing me to be with you today to share NCPDP's perspectives regarding a model designed to better assure safe use of opioids, maintain access for those with legitimate need, allow state and existing state PDMPs or prescription drug monitoring programs to realize their full potential, and to do this in a way that assures patient privacy and reduces provider burden. I would also be remiss if I did not mention that this system has direct applicability to the testing, the treatment, and the eventual, hopefully soon, immunizations related to COVID-19, as well as CDC's system modernization efforts relating to this pandemic. I bring this up because there is growing evidence that's already been mentioned that the physical and the social isolation associated with the current pandemic has led to a significant worsening of the opioid crisis. Now, a little bit about NCPDP, the organization. NCPDP is a not-for-profit, ANSI-accredited standards development organization located in Scottsdale, Arizona. Its stated vision and purpose are to lead the industry in creating healthcare standards for the common good and to standardize the exchange of healthcare information to improve outcomes. Membership is comprised of approximately 1,700 representatives from all sectors of the healthcare industry. Decisions are made using a consensus building approach with an obligation to be non-biased. So for the over 40 years of NCPDP's existence, it has been using this very defined process and serving as a problem-solving forum for the healthcare industry. Those results include things like various published solutions and industry guidance, and maybe most significantly, several electronic interoperable communication standards used in healthcare, many of which have been named in federal legislation and/or regulation. The two most prominent are the telecommunications standard and script. Telecom is the real-time bidirectional communication standard that connects the community pharmacy with the payer and other entities. Virtually every community pharmacy has been utilizing this standard for more than 3 decades, and today that represents billions of transactions literally annually. Script is also authored by NCPDP and is the communication standard on which all outpatient electronic prescribing is based. This standard is also real-time and bidirectional, and it connects the prescriber to the pharmacy. The advantages of utilizing electronic prescribing are many and serve as the basis for why many states have considered mandating its use. A little bit about NCPDP's involvement in the opioid crisis specifically. As I mentioned earlier, NCPDP has long considered itself as a problem-solving forum. And in this case, several of our members came to us many years ago and asked if we would examine this issue in more detail. Specifically, the ask was to examine several perceived gaps in the patchwork of prescription drug monitoring programs that were emerging at the state level. Things like data latency, inaccurate or incomplete data, difficulty in accessing the data, workflow issues, and challenges relating to sharing data beyond state boundaries. The result was the development of a PDMP task group at NCPDP and the creation of a white paper that highlighted several recommendations. These included the creation of a national facilitator hub, further leveraging those two NCPDP real-time bidirectional communication standards, telecom and script. And thirdly, and maybe very importantly, shifting the primary emphasis from law enforcement to clinical decision support. Doing these 3 things, it was thought, would close many of the perceived gaps in the current system, make the current state PDMPs better and more efficient, help to assure access for those with legitimate needs, and substantially reduce provider burden while also maintaining patient privacy. In short, this solution utilizes existing infrastructure and data streams, connects prescribers and pharmacists to a national facilitator hub via 2 real-time, bidirectional, HIPAA-compliant standards as a means of providing those entrusted with the care of patients with complete, timely, and accurate information on which to base their clinical decisions. And while the opioid epidemic is an extremely complex issue, NCPDP believes strongly that utilizing this approach will go far in helping to reverse this deadly trend. I want to thank you for your attention, and I look forward to our discussion. Thanks.
Well, thank you very much. And I think we have a lot of work to do in the standards and data collection. You know, sometimes in this work, we discover decisions that were made by previous legislators, often 10, 20, 30, 40, 50 years ago, that now have unintended consequences. And one of them is the decision about the handwritten script instead of the electronic script for opioid medication, which obviously the chances of fraud are actually much greater. So I think there's a lot to be learned in that regard as well. Next up, we have with us Rachel Uslick, Vice President of Clinic Services at Twin Cities Orthopedic. Rachel, thank you for being with us.
Yes, thank you for having me, and thank you to the task force for the open discussion about the opioid epidemic, especially after the COVID crisis. Our practice is 120 physicians, non-operative and operative orthopedic surgeons who came together back in 2016 to really assess and understand not just their prescribing practices post-operatively, but also their patient consumption and disposal practices. That was the focus around the past 4 years of our data use in the practice. Through those 4 years, we've looked at over 20,000 patient studies or patient cases, focusing and asking those patients how many of their pills did they actually consume, how many MEUs were actually prescribed, and actually trying to break down the data to the level of the procedure in which is being performed in the orthopedic setting. We were finding that our providers were not prescribing based on literature or research, but actually coming into medicine and their mentorship as to how they should be prescribing, and that carried on through their careers. As we started this data collection and analysis, our patients actually started to tell us, provide us feedback around prescribing patterns, and that they didn't want these remaining pills at home and how could they dispose. So our physicians partnered with Verde Technology and started providing disposal bags with any prescription written to go home with the patient, to make sure that any remaining narcotics were disposed of appropriately, so that we could reduce the burden in the public and the unintended consequences. Over the first 3 years of this study, we went from prescribing 12.8%, we went from 12.8% of our patients who had surgical procedures not receiving narcotics, to increasing that number to more than 46% of our patients not receiving narcotics postoperatively. That is one of our most proud moments in the practice over the past 3 years, is to see that transition and educating patients to non-opioid use pain management. A part of that evolution also started to begin the conversation around non-opiate educational pain management. So how could patients use other modalities, other resources to manage their pain, and also educate to what is perceived pain versus the actual level of pain that might need further intervention. Technology for us was on the level of data use and data analysis, where we found a gap as we've participated and collaborated with other orthopedic groups, is the challenge in actually being able to fund qualitative studies in practices and have resources to be able to understand how their providers are actually prescribing. The focus in private practice and in hospitals that we've aligned with just don't have the bandwidth and the resources to pull all of this information together. So as an organization, we are trying to take on that burden for groups and support the initiative by analyzing the data and finding an alignment. Our ultimate goal is to actually have prescribing reference cards, which we've actually produced. We're now on version 3, where a provider can actually look at a procedure in which they are performing, like a carpal tunnel, and across the header of the card be able to see different medication options and what the prescribing quantities maximum should be for a procedure that's being performed. That data is found on how patients have reported pain management, any prescriber we're actually seeing with consumption patterns. As our prescribers reduce their prescribing patterns, our patients actually more quickly reduce their consumption patterns. That was a huge aha for us, where our physicians started to realize our patients are savvier than how fast medicine is actually turning. And so we brought patients into the mix, had their voice at the table, reviewed data with physicians and patients in a room to talk about what is the need and how do we further impact the opioid crisis. I think one other area that would be of help is to be able to support dialogue and interactive reporting for providers at point and click. Our study was able to give providers data within a 24-hour period of collection, where providers could go in and see how they were prescribing, how even their allies are prescribing. So PAs, nurse practitioners that are supporting a physician practice, we realized as reports were produced, there was a disconnect in expectation of the surgeon's change in prescribing practice to alignment of their allied provider. We've since closed the gap, but the way that adoption, conversation, and collaboration happened in this entire project was through the use of quickly turning around data analysis. If data was years old, they wouldn't buy it. They perceived that they had already changed their practice. So we knew if we were going to talk about something, I had to have no more than 24-hour day old data. And that's where our success of adoption has come into play. Now that costs money for practices, the database resourcing, being able to access your patients in an electronic format so that they can return information back to you to understand how they're doing, is an expensive resource. But I think our study, TCO feels our study, has proven success as we've continued to improve and reduce prescribing as well as consumption patterns for our patients. Over these next few months, we are actually looking at prescribing and how that has impacted the patients with delayed care over the COVID period. So in the state of Minnesota, our ambulatory surgery centers were closed for about 10 weeks of time. That in turn delayed treatment for some of our outpatient total joint patients, which is the population that we know consume typically higher levels of narcotics. They also couldn't receive less invasive options, such as injections, to manage their pain. And so now we're trying to figure out, is there more validity behind delayed treatment and what that looks like as it relates to narcotic consumption, and then resulting in functional improvement decrease or delay. Thank you again for the time. I'm excited to learn more about our other panelists' work and the dialogue to come.
Rachel, that's fascinating. Thank you for doing the research and for sharing the research. I am a hip replacement survivor. and actually, it's amazing. I ski and bike and do everything. But I'm very, very cognizant of these patterns. In New Hampshire, one of the things we learned when we were first in the nation, regrettably, with opioids abuse, is that for some reason we had twice the national average of opioid prescribing. So we have really had to turn things around with our orthopedics and various surgeries and surgeons. This was another aha moment that we all faced when we learned early on that there was an unintended consequence of Medicare, Medicaid quality indicators that the surgeon said to me, we're between a rock and a hard place. And when they explained it to me, they were just giving out 30 pills routinely, or 30-day supply, because they wanted their patients to give a high quality report on the surgery. And they said, we're good surgeons. I don't want somebody whining about pain a week out to say it wasn't good surgery. And so it was feeding this desire, and their offices couldn't handle all the repeat phone calls and then back to the handwritten scripts. They couldn't handle the people coming in to get 10 more pills. So they just said, fine, take 30. Wait, here's 60. Let me give you 90. And they were just flooding the zone, flooding people with opioids. So that's a really important study. And thank you for that, also that point about the data and how quickly, you know, when you're trying to change minds and change people's behavior, that's really important. So, well, I am thrilled to welcome from New Hampshire, Dr. George Bleich, who's from Dartmouth Hitchcock Medical Center, which is a unique tertiary center with the Dartmouth Medical School in a rural community. So it's quite unique nationally, and we're proud to have you here, Chief Quality and Value Officer. So George, the floor is yours.
Thank you so much. And I also want to thank the task force for convening this roundtable. You know, first and foremost, I see myself as an anesthesiologist and a pediatric anesthesiologist that's practiced for over 30 years, and almost all of that at Dartmouth Hitchcock Medical Center. But I'm also a patient safety researcher, caught the bug on that back in the early 90s. And in the last 8 years have been in the chief quality role. I really want to thank Representative Kuster for sponsoring a bill that's going to extend standard monitoring that is really based on spot checks for inpatients in the hospital who are on opioids to continuous monitoring, and it's going to save lives. You know, as an anesthesiologist, I see every day how impactful opioids are in a positive way in managing acute pain. And from cancer pain to surgical pain, these are amazing, necessary medications. On the flip side, like any medication, they need to be prescribed appropriately, and we've heard that loud and clear. But even when prescribed perfectly, the idea, you have to recognize there's two major hazards with opioids, and one of those is that a subset of people, and it's hard to predict who, are going to have slowed breathing and in some cases stopped breathing. And if not recognized immediately and treated rapidly, I mean minutes, not hours, minutes, the person will die. The other big risk we've heard mentioned in multiple ways, and that's the risk of addiction. And it was underrepresented, and we need to really recognize that was always a risk, and we need to mitigate that. So that's sort of where in my quality role, you know, when we look at, and I think people are often shocked when they hear that people are dying from opioids while in the hospital. So I want to describe that a little bit and frame the research we did around this. You know, it turns out, and I want to connect it to the opioid epidemic, 35% of all opioid overdose deaths are tied to prescription opioids. And some of those deaths are people who've had everything done appropriately. They're not misusing, they simply are getting their medications in the hospital. And here's what that looks like. You might have a nurse post-operatively managing someone who's had a hip replacement. That nurse is on a low-risk population, typically managing 4 patients. And the current standard of checking on those patients' vitals every 2 hours is such that they could be really busy giving out medications and then come back to a room to find a patient is dead. And while they were busy in one room, that patient was developing that slowed and stopped breathing. And because spot checks just aren't adequate, it gets missed. So, you know, what we did that I want to share is we had one of those seminal cases while I was patient safety officer, and organizationally, like most, we do a deep dive on what we can learn from that and could it be prevented. And the truth is, we've had the technology and capabilities to prevent this from happening. So we implemented in 2008 continuous monitoring of oxygen with a little probe that goes on the finger. For all patients. Actually, we started with opioids, but we've extended it. And, you know, this systematic approach we took to also make sure when a patient gets into trouble, it notifies that nurse. So a nurse who has 4 patients, all 4 are being continuously monitored on this safety net system. It also, if they don't respond when there's a serious problem going on, it escalates and notifies their backup, and their backup's backup. What we did is we ultimately spread that to all of our inpatient beds, over 231 in 2.5 years, and have had a decade's experience. And what we recently did is look back over that 10 years, and we have had 0 of these incidents where patients were found dead in bed, where they had had an opioid. They had an unexpected, which is often the case, reaction, and were one of those rare people who are extremely vulnerable to even small doses of opioids. And it went undetected. We eliminated that. So given the 35 million people who are hospitalized in acute care facilities annually, and that 50% of them receive opioids, and about 1% of those who develop are likely to develop some respiratory depression. That's about 180,000 individuals a year at risk. And you know, thankfully, the vast majority might have a family member in the room, or enough people coming in and out of the room that they're picked up. But it's not 100%. And what we proved is that with continuous monitoring, we could eliminate this problem. So the pulse oximetry I mentioned is one way to do it. It's also been done with monitoring breathing with carbon dioxide at the nose. But the point is that these systems and tools exist, and we were able to show from the before period to after a huge reduction. In the several years prior, we had had 3 of these incidents. So, you know, in conclusion, I again really do want to thank Representative Kuster for sponsoring this bill. You've kind of heard the research and our direct experience. This is not only doable, it's sustainable, it doesn't break the bank. I think an important connection I want to make for people is, you know, if we can do this for inpatients, we can also extend it to outpatients. The technology is there. It's being done in a variety of settings with a variety of companies, but one that we've worked with definitely has a portable version that through a cell phone can connect through the cloud to our organization. And the truth is this happens on outpatients who have oral meds, again, appropriately prescribed and without any misuse. And sadly, this is a story that too many of us have heard of individuals who are found dead in their home after relatively minor procedures. But frankly, hysterectomies, knee replacements are all being done same day now. And we're going to need to manage this in the home. And thirdly, people who are in treatment with medication-assisted therapy do have relapses. And I can imagine ways this could extend to allow us to monitor people who are trying to get help, are trying to comply, but they're going to have some relapses. And what a shame if in the middle of those they die. So again, I really thank the task force and in particular Representative Kuster for recognizing this and helping us take a small but really important step.
Great. Thank you very much, Dr. Blake. I appreciate it. So we're ready to head into our member questions. I will let my co-chair, Mr. Fitzpatrick, go first. And then just to give people a sense of the order, David Trone, we'll go back and forth, Republican, Democrat. I think I still see Representative Steve Shabbat is with us. Brad Schneider, I know you want to speak. I don't know if Representative Johnson is still with us. Grace Meng has been with us from the beginning. Thank you for your patience. And Representative Jimmy Panetta. And if we have other members join, some of the member names that are up are actually staffers, but just let us know, Representative Bass's office, Representative Capter's office, if your member would like to ask questions. And with that, I will turn it over to my co-chair, Representative Brian Fitzpatrick.
Thank you, Annie. Thanks to the panelists.
You behind him.
Yeah. Thanks to the panelists for being here. This is obviously this is a passion for all of us that are on this task force. And I think the one thing that's been on all of our minds is because a lot of us felt that both from a policy standpoint and a results standpoint, we were making an awful lot of progress in this fight against not just opioid addiction, but addiction in general. Andy's done a tremendous job focusing on the mental health aspects of this, the stigma aspects of it, which, as you all know, is very, very important piece of solving this. But if I could just get all of your thoughts, and I know you've touched on this briefly, but the effect that COVID-19, it's had a ripple effect on a tremendous amount of things in our lives and in our country and in our world. And I don't think that the effect on treatment and recovery has been given enough attention. Not only was treatment not available for people during times of quarantine, but the quarantine period itself, as many of you know, people that are struggling from addiction are battling demons and they need outlets, they need that light at the end of the tunnel. And obviously that period of time when our country was shut down was not a light at the end of the tunnel for really anybody. It was very, very tough on even the mentally healthy people. Anybody that's dealing with any mental illness or any addiction problem, really, it was exacerbated, I believe. And sometimes, as we know, the results of these or the manifestations don't take hold for quite some time. So I just wanted to get all your thoughts on that because I know this is, the first meeting we've had really since we've been on the downslide of this. Let's start with Mr. Wall.
The unfortunate part, Congressman Fitzpatrick, is that colliding epidemic. the most remarkable thing about this is it seemed like the opioid crisis and the addiction crisis might have been starting to plateau a little bit, but come February, March, there's been an obviously increased use of addictive medications, and more relevant to this panel, an increased retention. So people are holding on to their medications now because it has become so much more challenging for them to find replacements if they need them. And that's why, I'm so excited to hear from the other panelists about the use of data, because all of the solutions we talk about, whether it's Deterra bags, Rachel, that you talked about, or some of the other solutions, they're great, but they don't produce the data that's required. Why are people hoarding their medications? And more importantly, from our perspective, what is the reason you're returning them? Are you being a good steward? Are you trying to clear out your house? Are you doing the things that your doctor or your nurse or your other prescriber are telling you to do? So from our perspective, we need to know why people are keeping them, and then what motivates people to bring them back.
Yeah, I would be happy to speak to the data that we collected, Jeff. And our patient said at the highest prevalence that retention of narcotics or opioids prescribed for pre-surgical or orthopedic purposes, the retention of them was in anticipation of painful therapy or what their peers had, or family members or others that have gone through therapy. It was the perceived pain that would exist after surgical intervention or continuation of orthopedic treatment. That was the retention purpose. When we asked about why people were disposing, when answering that yes, they properly disposed or indicated how they disposed of their remaining opioids, their biggest concern, this evolved over the 4 years, but it ended up being the biggest concern, was fear of a diversion out of their homes. They knew that they weren't saving them properly, that they were unsecured, they had kids in the home, and the kind of blessing out of all of this is that the media was heightened around the crisis of opioid addiction. And so that is a part of what we perceive as our patients' awareness trending faster than our surgical awareness, at least in our study. Dr. Blake?
Yeah, so I'll sort of share a little bit of the perspective of major medical center and delivery system. I'd say one of the things that as I talk to colleagues across the country that seems to be universal is that patients did defer care, and when they came back, they were sicker. All of the organizations are seeing that they really can't sort of stop deferring, or defer things indefinitely. So they're not only managing the COVID care, but they're also trying to manage regular operations. And it's producing stress and fatigue. And I think the comments in the opening around behavioral health, boy, we're seeing that in spades. And so all those things together are creating conditions where all of our areas have capacity challenges. We're seeing workforce challenges across the board I've never seen in my career. So we have a fatigued group of people out there that know that we still are going to have to do this for a while. But that is it's showing up in many, many ways, and I think people have hit on different aspects, but almost everything that we're doing, we're seeing relative workforce shortages and increased demand. And those two are really putting a lot of stress.
I'll just, and Congressman also, and I agree with all the comments that have been made thus far, but the reports we're getting regarding the degree of the problem is somewhere between 30 and 40% increase in the opioid scenario and the problem. On the good side of this, if there is a good side, I think we're finding ourselves in this new sort of world of telehealth and in a different way of presenting ourselves as caregivers. And to the extent that mental health can be utilized to a greater degree in this new world that we find ourselves in. I think in some cases it's working pretty well.
Steve, one of the things that we fear is the lag time to establish how these colliding epidemics are affecting caregivers themselves as diverters. So we're all here talking about patients as diverters and the recipients of these medications, but how about caregivers who have access and few controls and a lot of knowledge that the lay public doesn't have about the effectiveness? And I know it started in ORs with anesthesiologists and CRNAs, and I teach them a lot about how to avoid those kinds of temptations. But it's gone to every aspect of the hospital, every unit in the hospital. And you know, at what point are we going to start to see the data about increased diversion by healthcare providers?
Unfortunately, it didn't happen.
I really appreciate all of your perspectives, and I just want to have one ask of each and every one of you. Please stay engaged with our task force. You're offering tremendous perspectives. Andy and I and members of our task force, obviously this is a passion of ours, but we're dealing with a bazillion issues and putting out fires every single day. You people are the ones that will keep us focused on this. You have unique insight, unique perspective that can really help us craft good, from the legislative and policy standpoint, good solutions. So please stay engaged. That's my one ask of you.
Thank you, sir.
Great. Thank you, Brian, Representative Fitzpatrick, for your leadership and for being with us today. And I really appreciate the connection with mental health, the co-occurring illness, and that glimmer of a silver lining that telehealth has brought to mental health, particularly for those that had challenges getting time off or getting to the appointments. So that's one piece, and we'll look forward to working in a bipartisan way on making sure that we continue that option for people. And with that, we'll turn it over to Representative David Trone. I introduced him to you at the beginning, but David is a new member of Congress elected in 2018 who put together a really very impressive task force of his own on opioid addiction. And we welcome you, David. Thanks for being with us.
Good morning, everybody, again. And I really want to thank Chairwoman Kuster and Co-Chair Mr. Fitzpatrick. I mean, you guys have just been spectacular. You've been great friends, great to work with together as we all try and tackle what I think was the most pressing problem in America prior to COVID. And we can see those parallels with the death rates, COVID just hitting over 200,000. And we look at addiction in the last 3 years, the number is also over 200,000. But the difference is 2 points. One is there will be a vaccine for COVID, we believe. There's not a vaccine on the horizon for addiction. So this problem is with us, and we see the numbers in April, up 19% overdose deaths. In May, up 42% overdose deaths. So the problem is really, as we mentioned earlier, intensifying. So we really appreciate this attention to it today and working as a team. A couple quick questions. Ms. Uslick, you could help us out. What are the benefits and challenges of telehealth? We talked a lot about telehealth, and we've seen the weak underbelly of broadband on telework, telehealth, telemental health, and teleeducation, and the opportunities of fixing our broadband in America, which we have to fix next year, and we will fix that next year. But what do you see those benefits and challenges in terms of safe opioid prescribing and patient monitoring?
Sure. I'm not a provider, but I can give you some insight from what our providers have said in the practice. Telehealth during our state shutdown was absolutely beneficial for our providers to stay in contact with their patients, do simple check-ins where the patients felt like they were in a safe environment. Our telehealth volume has actually significantly decreased. We're now only at about 15% of our encounters are functioning through telemedicine at this point. The infrastructure was definitely a challenge for us, the technology infrastructure, especially for our rural patients, which are some of, as we've networked in this opiate community, our rural patients are the ones that are of some of our highest concern with consumption patterns and lack of disposal. And those were the ones that we had a really hard time staying in touch with, our farmers, our farming families. If there is an opportunity for us to make sure that we can enhance that opportunity in some way to stay connected, to get eyes on patients and help with some of the anxiety that I think has elevated through the COVID periods, which I think has subsequently probably caused some more consumption pattern increases and addictions, that would absolutely be beneficial for our providers. And sustaining the reimbursement pattern so that we can keep the infrastructure and keep up with the expense of maintaining telemedicine for the practice.
Yeah, absolutely. We've got to sustain what we got started with COVID. We can't let that slip back. So we're definitely on that. Mr. Wall, what do you see 10 years down the line in terms of technology to help us prevent diversion on prescription opioids?
That's a terrific question. I think in terms of technology, we're going to substitute technology for the honor system. You know, there's so many other aspects of life as we know it where what we do is confirmed or validated or verified. You know, if you're depositing $1 million into your Bank of Baltimore account, Congressman, they're going to want to see the check. They're going to want to see the $1 million before they post it to your account. So we believe the same thing needs to happen short-term and long-term in terms of how you handle your medications. And one theory that was put forth by a doctor named Evan Karish. Evan is an anesthesiologist at Duke and actually is sort of the voice of the American Society of Anesthesiologists. And he looks at opioid prescribing not as a gift of medication or a right to have it. He talks about it as a loan. So think about it like this. Let's change the paradigm shift. When you get medication, you have an obligation to be a steward of that medication. And when you're finished with those medications, you have an obligation to repay that loan and return them responsibly. So we think a combination of that and the paradigm shift will help us with technology in the next 5 to 10 years.
Yeah, that's interesting. To follow on the same vein about the unneeded opioids, Mr. Mullenix, in terms of prevention, how important is it? Again, let's talk some more about getting these unneeded opioids out of the home. But where does the pharmacy itself, the connective point, what should their role be in this in the future?
Yeah, and as a pharmacist, I can tell you, I think the hesitancies that were prescribed by Chairman Kuster earlier about obtaining return medications, I think what you're going to see is a policy change. I can tell you over the last several months, there has been an uptick of accepting controlled substances back in these take-back programs, a substantial increase at the pharmacy level. So I think that will continue. From a policy perspective, you know, one could say if the pharmacy dispenses a drug, they then could also be responsible for taking it back. I mean, there could be some sort of assignment, you know, a reasonable assignment, properly organized. But the concern has been historically practicing as a community pharmacist many years ago. I can tell you, having a large supply of return medications that could not otherwise be dispensed from that pharmacy after it had once been dispensed was a challenge. So I think technology will play a role, as Jeff had mentioned earlier. But I think policy will continue to recognize the importance not only of prescribing the appropriate amounts of these medications in the first place, but also having a reasonably accessible way of returning them outside to get them off out of the medicine cabinets of individuals.
And I assume there's no effective way to, on returned medicine, to validate again what it is and then recirculate it. That just doesn't happen. It's all disposed of and wasted.
Well, interesting you mentioned that, Congressman, because I'm aware of some emerging programs that are actually, for lack of a better term, they're organized as redistribution centers. They have primarily been focused, they've been legislated state to state, but special circumstances and under pharmacist and professional supervision, they're called take-back programs that actually utilize these medications, reutilize these medications for the indigent and the underserved. And I will tell you that there's a tremendous amount of interest in this across the country. It's hard to argue against it if properly organized. You know, the difference between throwing these, as it was mentioned earlier, down the toilet or down the sink versus repurposing them for people who otherwise would not be able to obtain anything. So I will tell you that is an emerging issue here right now.
One of the other issues relating to that is whether you can sell medications or redistribute them past the use-by date. There are some issues whether a drug is actually efficacious at what period of time past the sell-by or use-by date. Obviously, Congressman, it's easier with prepackaged blister-packed medications than it is with bulk fill medications, in an amber vial. That would be a little more challenging. But there certainly are aspects of that, and in fact, we are looking at that as one of the technologies that we can improve using our system.
Thank you. Those are interesting ideas. I yield back.
Great, David, thank you so much. And I'm delighted to recognize my colleague. It looks like Dr. Blake, do you want to join in on that before we move on?
Yeah, I just, if I can, make one comment about the telehealth. I so want to thank Congress for the CMS waivers. Being an academic rural health system, these were so pivotal. And, the comparison, even the audio only, was a lifeline. We have often talked about other safety issues around, and I'm asked directly, safety issues around telehealth compared to regular visits. And my colleagues and I remind people the real comparison group should be no care at all. And so again, enabling that, I just really wanted to make that point, and thank you all for that.
Great.
It would be nice if we could keep those waivers going, because I think they're relevant even after the COVID epidemic is over.
Absolutely, that's our goal. So I apologize, we're going to go back and forth, Democrat and Republican, and I'll call on my colleague, Representative Steve Shabbat. Mr. Shabbat, you are on if you want to unmute.
Thank you. Yeah, unmuted myself. I want to thank you, Ann, and Brian Fitzpatrick for your leadership on this most important issue. And I'll be real brief. I want to apologize for being a little bit late. I had 2 other committee hearings. I'm bouncing around as we all do, unfortunately. So we get bits and pieces. It just happens, occupational hazard. But my question was basically, I mean, we've done some relatively major, this is my 24th year in the House, and this is, drugs isn't new, but opioids, relatively new in recent years. But relative to what we've done in trying to do what Congress can do to help, we obviously passed the CARA Act. I know Senator Portman was very involved in that in my state, Ohio. I represent Cincinnati, and both most of the city and the surrounding area. And, we do have challenges. Hamilton County's had a lot of opioid deaths over the years. We had some improvements, but it's tough. And CARA was one of the big things that Congress did. And then the Support Act was another big one. And I'm just wondering, are there things out there either that we're missing or that you think that we ought to be focusing maybe a little more time and attention? And obviously money, because that's the one thing we do have up here, even though we really don't have it. We just put it on our kids and grandkids' debt until we ever balance this $23 trillion, huge national debt we have hanging over our head. But nonetheless, we've got this issue facing us and we can get money out there. What are the one or two things that we ought to be really focusing on right now? How can we help? That's my main question.
Congressman Shabbat, hello from the north coast of Ohio. We're based in Cleveland.
Good job.
The thing that I would like to mention is, unfortunately, Cleveland and Ohio have become the focus or epicenter of the opioid crisis, not because it's necessarily particularly worse here than it is in New Hampshire or anywhere else, but because we're the site of the multi-district litigation. We're the site of all the lawsuits. So what I would like to propose, and tapping into the Support Act, tapping into CARA, the ones that you mentioned, we need to look at Ohio as the place where the solutions are developed, not the litigation. And that's hard for a lawyer like me to say less litigation, but we need to take all of the stakeholders, the distributors, the manufacturers, the retailers, the physicians, the nurses, public health experts, and get them at a round table or any kind of table to all talk rather than suing each other and blaming each other for where we are right now, and look at how each of them with their respective positions and interests and expertise can help solving this problem with the help, of course, of the federal government.
Although I'll just jump in here very quickly because it relates to your comment about the taxes. I think with the bonuses that were paid by Purdue Pharma that are just shocking to the conscience, one of the things about the litigation is that we will come up with the funding for some of these programs from the private sector that had such extraordinary gains at the detriment of people's lives. So I don't mean to get too political, but I know Mr. Shabbat raised the issue of tax dollars, and some of this money needs to come for the private sector. But let's go ahead. I think Mr. Mulinex, you had your hand up to respond to Mr. Shabbat.
Yes, and I'll sort of expose my bias here. The community pharmacy has in many ways been a leader from a technology standpoint for many, many years. Originally primarily for payment, but increasingly for documentation of services and other reasons. So I think we haven't leveraged the true capabilities of existing data channels that already exist. And I also believe that in many cases, those channels have operated in silos. So we're talking about further utilizing existing data streams, but also making them and assuring that they're interoperable with the other members of the healthcare team to be utilized maximally for the benefit of patient care.
I'll jump in. Although there's been a lot done in this respect, we had talked a little earlier in this panel on the co-occurring crisis with behavioral health in general, and opioid use disorder certainly falls into that. So access to medication-assisted treatment, continuing to allow us to expand those who can offer it, prescribe it, 75% reduction in mortality when people get onto a treatment, and obviously need to sustain it. So when we're working the behavioral health challenge, we are working the opioid overdose death problem. And I think I would double down on everything we could do there.
Thank you.
Great. The other thing, Mr. Shabbat, I just wanted to add, because I should have explained this to everyone at the beginning, but the way the task force works is that we work in a very bipartisan way, and each year we put together an agenda of bipartisan legislation. So in order to get a bill onto our agenda, you have to have Republican and Democratic co-sponsors. And working that way, we've been extremely successful. You mentioned the CARA Act, the Support Act. We've had literally dozens of bills that have come out of members of this task force. And I'll make sure that my legislative assistant, Marissa Salome, follows up with your team to make sure that you have that bipartisan agenda, and that we'd welcome you to get on those bills as they're moving through if we can get a handful done before the end of this Congress, but obviously picking right up in January. So thank you for being with us.
Thank you, Ann. Look forward to working with you.
Look, sounds great. Thank you. By the way, I'm an old college friend of Rob Portman, so give him my best when you see him.
Oh,
And
I'll do that.
we were at Dartmouth with where Dr. Blake works now. And small world here, because our next speaker, Representative Brad Schneider, had a son at Dartmouth as well. So, and it looks like he had a recent accident. So now you have become an expert on opioids as well. Thank you, Brad.
Actually, have Mr. Molnix, you seem to have something you want to add to the last one. You were raising your hand. You're on mute.
You need to unmute.
Thank you. I appreciate that. Yes, what I was going to mention is something that I sort of call attention to something Dr. Blake mentioned earlier regarding the introduction of pharmacogenomics. There appears to be some aspect here related to how individuals respond to opioids and process them, and even some tendency toward addictive behavior. To the extent that that develops, you know, in the research environment, I think you're going to find that being sort of a prior authorization kind of action that will be necessary. Maybe it'll prompt the use of, you know, the dispensing of narcotics along with the opioid itself. Those kinds of decisions will help to assure safe use in the future.
All right, thank you. And I want to thank everyone for sharing your time, but also sharing your insights with us today. And as Congressman Kuster mentioned, Dr. Blake, my son did go to Dartmouth. He's 15. But relevant to our conversation here, 3 weeks ago he had a bike fall, and 2 weeks ago he had surgery on his shoulder, elbow, and wrist, all on the same day. And Dr. Blake, as you mentioned, it was outpatient surgery. My wife and I actually flew out to San Diego. He's in the Navy, and stayed with him. She's still with him, helping care for him. But it is becoming an increasingly is becoming the responsibility of family or friends to take care of patients. And I think there's things we can do there. But my question now is, you know, a number of you have talked about the importance of having data, grabbing data. Congress has put a lot of money into trying to collect that data. It's only as good as the information that comes from it is only as good as the quality of the data going in, but the information is only useful if it's being used, if it's being accessed. So I'd love to get a sense from you, a sense of how these different databases are collecting data, how they're communicating with each other, how doctors have been uptaking the access to that data.
I'll start. I can tell you that one of our surgeons on starting to have real insight around the overprescribing really jumped on this. Dr. Rick Barth, he's a general surgeon and has done a ton of work to sort of replicate what Rachel mentioned earlier, that we really, our patients, when you talk to them and collect that data, need far less than was thought, and it wasn't really as tailored as it should or could be. And that work has happened and been really spread across our organization. But the data was pivotal, and the ability to also benchmark and see what others doing would only accelerate that. So that's one small piece of it. But absolutely, we are constantly looking for registries, national data sources. Benchmarking is the quickest way. If someone is doing something better, we in safety and quality don't compete. We share and we copy and sort of all teach, all learn.
Rachel, Ms. Hughes, like you raise your hand.
Yeah, I would just like to echo Dr. Blake's statement of when we partner with hospital quality departments or other private practice quality departments, it's very easy to share data, unblinded data. However, when we start navigating out into the pharmacy world or out into other spaces, that data sharing all of a sudden becomes very restrictive, complicated, contractual to a certain degree, even with our payers, where we personally feel we could find a lot of value in understanding more about our patient base and how we can collaborate even further. And I think if there's one ask out of our business, it would be how do we encourage that collaboration in a non-confrontational way that allows for open dialogue and sharing of information and ultimately resolution to this problem. So,
Mr. Wall, you wanted to add?
Thanks, Congressman. We look at the data as having two different levels. One is what we talk about as the micro version, which is between prescriber, provider, and patient. So how can I do better for you as my patient based on your own usage habits? And the other is the macro view, which is really what Rachel talked about, the aggregation. So for example, you'll have, patients in your orthopedic practice, Rachel, or patients in a hospital in Hanover who have the same procedure. You can aggregate that data and find out what the relative average usage is for patients having that procedure, and not to create care pathways and firm, bright lines that you can't go on either side of, but really to set guardrails. So if a particular patient wants additional medication, it might raise flags to indicate, does that patient have a problem? Is that patient just a low pain threshold patient? But you need to keep an eye on the ball, which is what are other prescribers prescribing for patients who have the same diagnostic criteria?
Great, thank you. Mr. Malnick?
Yeah, I think I agree with that approach. The guardrail concept is a very good one. It is not to dictate a treatment. It is to provide alert and allow some of the technology to do some of the heavy lifting so that it notifies the provider, in cases where there might be a reason to look a little deeper into the particular situation.
Great. Thank you. And with that, and I yield back.
Great. Well, thank you, Brad, for joining us and staying with us. I believe the rest of the offices that are on are staffers, but if you could let us know, Representative Karen Bass, Representative Capter, Representative Jimmy Panetta. I know my friend Grace Mang had to drop off for another obligation. So we're getting close to wrapping up, but please let us know if there are any other members out there who would like to speak. I did have a few questions, but interestingly, not surprisingly, we covered a lot of this during our discussion already. I wanted to ask about the opioid-related deaths in the hospital setting due to respiratory depression, but Dr. Blake, you did cover that. Staffers on the line just know that my office has legislation on that, on the standard of care for patients receiving opioids in the hospital setting. We welcome your members from both sides of the aisle to join us. Our legislation addresses the need for continuous monitoring for inpatient opioid use to put an end to these preventable deaths, and we'd love to have your members join. I'm glad that Dr. Richard Barth's research came up. I did have a wonderful opportunity to meet with him at Dartmouth Medical School, and he's got fascinating research, Rachel Ulick, just similar to yours on post-operative care and prescribing. And some of our legislation that we've gotten behind has to do with medical school training. We were shocked to learn that it's 2 hours of pain management and 2 hours of addiction treatment. And so we're trying—
Brad Schneider, it's Mary Elliott.
We're trying to, work in that regard on changing the behavior. It was interesting, your comments about mentors and how they learn their prescribing practices and trying to change that. So I'm just going to close with one question here for Mr. Mullinex. I have introduced bipartisan legislation with my Energy and Commerce colleague, Congressman Mullen, to alert dispensers in real time when a patient is at risk for abuse or harm by a drug by using existing prescription and dispensing data to review a patient's prescription history, including fill attempts. Could you speak to how the current PDMP system has real-time data limitations? And I know you briefly touched on this, but I'd love to get some of my colleagues on board to that legislation with Mr. Mullen.
Yeah, I'd be happy to respond to that. Yeah. In the pharmacy today, under the current scenario, and by the way, you know, things have constantly improved over time, and there are a lot of very smart people doing very good things in this space. But in reality, these state-centric PDMPs, based on state law, that determine the pharmacy is actually dispensing, the pharmacist is dispensing the product in real time. And when I mention real time, I mean they're sending a message and getting a response, generally in under a second. And during that 1 second time frame, there can be as many as 1,000 edits occurring in that process. And traditionally, it's been about, you know, what is the copayment? Is the patient eligible for this care? Is there a drug interaction? Bob, you know, the list goes on and on. It's been primarily originally, as I mentioned earlier, around payment. However, under the PDMP scenario, depending on what state you reside in, the pharmacist waits a day, a week, or a month to create a report to send to a state website. What we're suggesting is that do two things. That information is already 95% of the time going through what we call a switch. And that's essentially a routing, electronic routing entity. Goes to the right payer, et cetera, et cetera. We're saying enhance that switch in two ways. One is hold an algorithm at or near the switch. And if it passes that algorithm regarding opioids and, you know, daily use, et cetera, multiple prescriptions, if it passes that, it goes on to the payer, comes back, and then it uploads, that information uploads for some period of time. At that point, the pharmacist is done. And that information is uploaded in that file, and it's immediate and it's nationwide. The state PDMPs then, based on their interest and capability, could and should, in my view, ping that database, that national database, as frequently or infrequently as they choose to do all the things they do today with regard to helping protect the health and welfare of the citizens that reside within their states. Only now they presumably would have a full picture of what the basis for that is. And so that's the essence of this effort. And rather than those PDMPs receiving, you know, periodic data, batches from, you know, 2,000 pharmacies periodically throughout the month, they now could get one ANSI accredited standards-based data batch that they could pull again as frequently or infrequently as they choose. That's the essence behind our effort.
Well, and what I'm interested in that, I come from a small state surrounded by small states, and a statewide PDMP doesn't really do the trick for us, because if people are seeking medication, they're going to go to Vermont or Massachusetts or Maine. And I've heard horror stories of people in the throes of addiction driving from one to the next and hitting up 4 pharmacies in 4 states. So Mr. Wall, did you want to comment on that?
Yes, Congresswoman. We would love to see a marriage of the very important PDMP data that Steve just talked about, the outgoing, how many scripts, how many prescribers, where they're purchased, where the doctors are, with the return data. So when a pharmacist goes to fill a script, whether it's at a chain or an independent pharmacist, and they do a NARCS check to see if that patient is at risk based on his or her PDMP history, now they can look at their return data and say, okay, Mr. Wall is a responsible patient because he is returning excess medications. So that quick transaction can become more valuable and more reliable, because now you know the front 9, which is the medication going out, and the back 9, which is how responsible that patient was by returning the excess medication. So we think it makes the job of the prescriber more robust, makes the job of the pharmacist somewhat easier, because you don't have to make a subjective judgment as to whether you should fill that prescription or not.
Well, and I think this ties in, Rachel, I'm thinking of you, and I'm glad you got your hand up. If you had that kind of information by the prescriber, then you could communicate you're outside the norm. Our practice group has reduced the either the outgoing or you've empowered. I like the idea that patients aren't given a lot of guidance. If the physician said to them, I'm going to give you 20 pills, but if you only use 10, which was what I recommend, then you need to return 10, and here's an easy way to do it, and we keep track, then you have much more accountability. As it is now, 30, 60, 90, and whatever you want to do with them, and nobody's going to take them off your hands. So Rachel, we're going to give you the last word. Any comments on that? And you'll need to unmute. Yep.
Sure. Yeah, thank you. I think one of the biggest gaps our providers are having is in their electronic medical record. They can see PDMP and see the frequency of prescribing happening. However, they don't see the fill. And so that is a huge gap that they're kind of flying blind, to be quite honest. And one of the challenges that our surgeons are feeling right now is the payers are implying all of these caps on fill requirements. Those change daily for different patients, different payers. And so there's this state of confusion and malalignment and to a certain degree, a little bit of frustration that I think if, like in this task force, we can come together and collaborate and say, what is appropriate? What are the risk factors? And how do we bring all this information together at one place and say, we agree to this, and let's at least start moving it forward, while understanding that we're going to have to be fluid and adjust with it as it goes, because this is evolving. The community is changing. The demands and needs of patient care is changing. If we can do that, I think that will make patient care easier, the patient experience and outcomes incredibly more successful, as well as a unique uniting front in healthcare to really transform the care platform that we are in right now.
Well, that's incredible. And thank you, all of you. And hopefully we've demonstrated to you that we have an open door and a bipartisan process, and we would be very, very interested in working with you in that collaboration and coming to resolution, because I'm very mindful that it's often federal regulations that are driving these unintended consequences. So thank you. Thank you to David Trone for sticking with me, and Brian Fitzpatrick and Brad Schneider. And with that, we will end our bipartisan task force on the opioid epidemic, and we'll look forward to our next meeting coming up later in the term. Thank you very much.
Thank you.
Thank you all.
Thank you.
With us.